Hello, everyone, and welcome to MSK Unknown Case Series, case number 47. Here we have a sagittal T1 and a sagittal T2 fat sat weighted image through the knee. And there is abnormality here. And the question that I have for everyone is, what's the most likely diagnosis here? Is this an ACL re-tear, a case of arthrofibrosis, notch impingement, or tibial tunnel syndrome? What's the most likely diagnosis here? And I think the key to understanding this diagnosis is to understand, first of all, that this patient has had an ACL repair, right? So you can see some of the screws here along the tibial tunnel here. You can't really see the femoral tunnel very well on these views, but this patient has had an ACL repair. And the key finding here is this abnormality here anterior to the graft that on T1 is heterogeneously hypointense or dark. And on T2, it is heterogeneous, but much of it is dark or hypointense, and maybe a little bit centrally is, hyperintense, but it's heterogeneously hypointense and it's dark on both T1 and T2. And the location is also very telling. It's anterior to the ACL graft. So the findings here would be most consistent with arthrofibrosis or a cyclops lesion. This is not an ACL re-tear. So in the case of an ACL re-tear, often we'll get bone marrow edema along the anterior lateral femoral condyle, posterior lateral tibial plateau, the classic pivot shift mechanism, and you'll see discontinuity and disruption of the fibers that are coursing through the ACL graft itself. This ACL graft was completely intact. There was no tear in the ACL. It's not a case of intercondylar notch impingement syndrome because there's often with that diagnosis, there's like an osteophyte at the intercondylar notch that exerts mass effect on the graft itself, resulting in impingement. There may be, a chronic sprain or intermediate signal, even partial tearing of the graft because of that mass effect. We see no evidence of notch impingement here. And there's also no evidence of tibial tunnel syndrome, right? So if you were to look at the graft, we see no evidence of, fluid or a ganglion cyst distending the tibial tunnel. Here, the tibial tunnel looks very normal in appearance. So the best answer here really is a case of arthrofibrosis or a cyclops lesion. And this is, the focal form, by the way, is termed a cyclops lesion, and that's due to the arthroscopic appearance of this. When orthopedic surgeons go in and probe this area, it resembles the color, like the bluish hue, similar to the color of an eye. So that's why this was the focal form of this is known as a cyclops lesion, and that's where it gets its name from. This, of course, is a focal area of fibrosis. So this is a reaction that occurs from the graft itself where you get fibrotic tissue that typically forms anterior to the graft, but it can occur in other places around the knee and the joint capsule. But most commonly, we see this anterior to the ACL graft. And this is a real problem because this can result in an inability to terminally extend the knee. So many times these patients can't extend their knee, and that can be a problem. And that's often what brings them to the primary care physician or the orthopedic surgeon, and then eventually to have an MRI examination to confirm or refute the diagnosis of arthrofibrosis. And the key imaging features for arthrofibrosis is looking at both the T1 and the T2 and looking for dark signal because fibrotic tissue is often dark on MRI, looking for dark signal on both T1 and T2, typically anterior to the ACL graft. That's the most telling imaging finding of arthrofibrosis. Very important diagnosis as a complication to the ACL graft. You should know this, highly testable on the core exam and other testing opportunities. So thank you so much for your attention. Please subscribe to the channel, support our mission of free education, and I'll see you again next week for another high yield MSK unknown case.